This recording will cover syphilis, a complex STI that can become systemic and cause serious complications, including death. It is caused by a bacteria, a spirochete called Treponema pallidum. The infection is usually transmitted by sexual contact and blood exposure, but transmission can occur through close body contact such as touching or kissing where there are open lesions. Untreated syphilis is divided into two categories, early and late, and it has 4 stages that it progresses through. Primary involves a localized canker. Secondary involves systemic illness. Early latent phase includes a seropositive or positive blood screening but no symptoms. And tertiary involves symptomatic infection. Neurosyphilis can occur at any time and in any stage, and patients with this form of the disease may experience meningitis, vision or hearing loss, and brain or spinal cord dysfunction. The appearance of an ulcer called a canker is the first sign of primary syphilis. It develops at the site of entry or inoculation of the organism, on average about 3 weeks after exposure. During this highly infectious stage, the canker begins as a small papule, approximately 1 to 2 centimeters in diameter with a raised margin. Within a week, it breaks down into its typical appearance of a painless, indurated, smooth, weeping lesion. Regional lymph nodes enlarge, feel firm, and are not painful. Without treatment, the canker sore usually disappears within 3 to 6 weeks. However, the organism spreads throughout the body and the patient is still infectious. Secondary syphilis develops in approximately 25% of untreated infected people within a few months. With this stage, syphilis is a systemic disease because the spirochetes circulate throughout the bloodstream. Commonly mistaken for influenza, signs and symptoms include malaise, low-grade fever, headache, muscle aches, sore throat, hoarseness, generalized adenopathy, joint pain, and a generalized rash. There is no typical appearance of this rash, but it usually appears on the palm, soles, trunk, and mucous membranes. It can appear as diffuse macules that are reddish brown, papules less than 5 millimeters, or pustules, scaly psoriasis-like lesions, or gray, white, wart-like lesions. All of these lesions are highly contagious and should not be touched without gloves. The patient may also have patchy alopecia on the scalp or facial hair. They could be missing a part of an eyebrow or have a moth-eaten appearance. The rash subsides without treatment in 4 to 6 weeks. Tertiary or late syphilis is uncommon because of the widespread availability of antibiotics. If experienced, it can occur over a wide range of years, from 4 to 20 years. This stage develops in untreated cases and can mimic other conditions because any organ system can be affected. Signs and symptoms include cardiovascular changes, such as aneurysm, heart valve insufficiency, or heart failure. Neurosyphilis, which can include progressive dementia and locomotor ataxia. Gametosyphilis lesions are on the skin, bones, or internal organs. The prevalence of syphilis is highest among Blacks and Native Hawaiians or other Pacific Islanders. Identify unique needs regarding sexual health and prevention and treatment of STIs for the LGBTQ community. Discrimination, healthcare disparities, and other healthcare provider lack of understanding can greatly affect health status of this population. Taking a health history that provides opportunity for the patient to identify sexual orientation, gender identity, and sexual activity is crucial. Gay, bisexual, and other men who have sex with men are at the greatest risk for contracting primary and secondary syphilis. When assessing the patient, gather a history about ulcers or rashes, take a sexual history, and conduct a risk assessment. A woman may report inguinal lymph node enlargement resulting from a canker in the vagina or cervix that is not easily visible to her. She may report a history of contact with a male partner who had an ulcer that she noticed during a sexual encounter. Men usually discover the canker on the penis or scrotum. When conducting a physical examination, be sure to wear gloves when palpating any lesions because of the highly contagious treponemas that are present. Observe for and document rashes or any type because of the variable presentation of secondary syphilis. The healthcare provider will obtain a specimen of the canker for examination under a dark field microscope. Diagnosis of primary or secondary syphilis is confirmed if the bacteria T. pallidum is present. Other diagnostics include blood tests that are based on antibody-antigen reactions. These tests determine the presence and amount of antibodies produced by the body and react in response to an infection by the bacteria T. pallidum. There are tests that are done to detect antibodies that are directed against treponema antigens. Patients who are shown to be reactive to one of these non-treponemal tests will have this positive result for their entire life, even after treatment. The textbook goes on to say that the patients may be surprised if this comes up during their examination, because they may feel that they've had treatment or maybe had recovered from it, but they're still going to show up as being positive. So we want to use therapeutic communication skills and a non-judgmental attitude to objectively discuss the finding. Treatment for the bacterial infection of T. pallidum that causes syphilis is treated with penicillin, frequently given as a single IM dose. This single dose helps to ensure that treatment is complete, since they're not required to take multiple pills. Be sure to monitor for an allergic reaction after administering penicillin. You want to keep the patient for at least 30 minutes and look for signs and symptoms of an allergic reaction. To provide teaching, choose a setting that offers privacy and encourages open discussion. Discuss the importance of partner notification and treatment, including the risk for reinfection if a partner goes untreated. All sexual partners must be prophylactically treated as soon as possible, preferably within 90 days of a syphilis diagnosis. Inform the patient that the disease will be reported to the local health authority and that all information will be held in strict confidence. Urge patients to keep follow-up appointments. Remind the patient to follow up for self and remind the patient that follow-up for their self as well as their partner is critical, and that sexual abstinence is recommended until full treatment is completed. After the initial antibiotic, the CDC recommends follow-up evaluation, including blood tests at 6, 12, and 24 months. Repeat treatment may be needed if the patient doesn't respond to the initial antibiotic. Emotional responses to syphilis vary and may include feelings of fear, depression, guilt, and anxiety.